Thank you, Mr. Chairman. Mr. Morse, according to this report, and many of us are talking about reports today, this is the HHS report, Office of Inspector General, on Medicare Part D, and it's on this issue of opioids that you touched on just at the end of your testimony, and I appreciate that. But what I think is interesting about this and draws a red flag for me is one of the things they talk about in here is a prescriber in my home state of Indiana wrote an average of 24 opioid prescriptions each for 108 beneficiaries in a year, costing Medicare Part D $1.1 million just to that Indiana physician. And I guess I am not a health professional. It draws a red flag to me. And I guess my question is, and I know you were probably getting to this on your statement, but what processes does CMS have in place to flag and investigate these suspicious prescribing practices like this? And what do you think needs to be done to improve the system? Because I'm guessing that you're going to say that here's what we do, and then you're going to say, yeah, we need to do more. And so my question is, what is the more? And to have gone through whatever the filters are, to have gone through one doctor in my state to be able to produce these kind of records, I think is astounding. So just from your professional opinion, where do we go on this? What else has to happen? And then what do we need to do as Congress to help you get those filters?
Thank you. We've reviewed that opioid report from the Inspector General's office also, and it is quite concerning. We've got a number of efforts underway in Medicare, both fee-for-service and in Medicare Part D, that try to address opioid prescribing abuses, as well as it's obviously been a major focal point of this administration, of the Secretary, of the past administration. CMS has an opioid strategy that it published in January of 2017 on this very issue, and looking at sort of all the various levers that an agency as a payer can potentially be sort of pulling to help to address the opioid epidemic. From the program integrity side, we have a number of things that we look at. We work with the Medicare program on the overutilization monitoring system. This looks at it largely from the beneficiary perspective, but it looks at, does the beneficiary potentially have too many prescriptions? Are there too many, potentially in this case, opioid prescriptions being prescribed in overlapping ways? And how do we kind of make sure that that is not
right? But obviously the filters that you're talking about didn't catch this, and so. From your perspective, if you had the magic wand and you could say, look, I'm over this, I studied this, I'm the professional, here's exactly what we need to do. Let's at least try this. What would it be? Because the other thing disturbing about this, there's 500,000 beneficiaries with receiving high amounts of opioids. So the filters aren't working. So whatever was done prior to January of 2017 is not working. So we take that off the chart here and we say that you say, what is it that we're not seeing here, and what can we in Congress do to help you get there?
We also have abusive prescribing authorities within program integrity at CMS.
Do you use them often?
We have used them only a handful of times at this point, because part of it is we need to be able to establish sort of that pattern in the practice. And when we see a pattern in practice, it often is then referred to
How long is a pattern in a practice? So my, who's your doc here that took this to the limit and over the top? So he's writing an average of 24 prescriptions each for 108 people in a year, and it wasn't flagged.
But when we do see something like that in our data, we flag it for law enforcement. So I mean, that's how those cases begin, though. So in that case, there may have been data that's from CMS. In this particular case, there may have been data that is from CMS that we then flag for our law enforcement partners who then begin those investigations. So when the behavior is that egregious, if it's something that we can see in our data, it is something that we need to be able to send to the Inspector General's office, to state law enforcement, to DOJ, and then they begin sort of the more serious criminal and civil.
So what happens now as a result of this report? Because still what you're describing is what's happening pre-2017. As a result of these egregious violations, what new things are going into play now?
Well, we're actually very pleased that the CARA legislation from about a year ago was passed, and CMS is working to implement the Medicare lock-in program. So lock-in is something that's been used very effectively by both state Medicaid programs as well as by private payers to be able to lock in a single beneficiary and a single prescriber. So essentially it helps monitor that overutilization and it helps sort of prevent that sort of abuse from happening.
I appreciate it. Thank you, Mr. Chairman.